Okay, I think that basically the thing with that patient is that you uncovered this kind of, I don't want to say ancient secret or principle or hidden truth, but you did. We'll kind of explain it as we go. Welcome to the Anatomy of Therapy podcast. I'm Dr. John Cybulski here with Bobby Riley. Today we're talking ancient alien secrets and why you should trust them. Go with them if they come. No, we are talking today about secrets of treatment. Seriously, there are a couple things I think that are very simple ways to look at treating patients that we often overlook. Sometimes we get a little bit stuck in our rut. Sometimes we need to get out of that rut. Sometimes that rut is good and makes you very successful. But I want to give you a little bit of perspective on just kind of connecting with your patients, I guess I would call it. How would you, I don't know, what would you phrase it?
Connecting, I guess if getting by and if it's possible, then you connect. But I mean, showing competence sometimes leads to confidence.
Sure.
So we're going to talk about, I think, displaying confidence clinically.
There you go.
Through communication with the patient, and that could lead to connection to the patient with the patient.
We're going to talk about treating fake things and why that's not good for treatment. And hopefully treating the most real thing. And I'm not saying that no knowledge is complete and that truth can neutralize any knowledge. I think that's the saying, but I'm not saying it. I'm not saying that. There's a patient you saw. There's a patient I saw that were kind of very similar. Let's get right into it. So much BS right now. There were a patient you saw, and I saw, very, very similar situations. Why don't you tell us that encounter? This is kind of like an initial consult. You guys were just during the consult phase, I believe, right?
Yeah. I just had a patient come see me from another chiropractor. It wasn't sent to me by the chiropractor. She had just been trying to get some treatment, was trying something different, wasn't really working. So she tried somebody else. And why she chose another chiropractor, I'm not so sure. If she didn't, hoping for a difference the next one. But luckily, I am a little bit different. So the real thing was she came in and I asked her, what's going on? Why are you here? How can I help you? That kind of thing. And everything that came out of her mouth was as if I were talking to her chiropractor. So
chiropractor.
She was, exactly. So she was just telling me the things that she was told. So, and that by the vernacular that comes, as the patient speaks, they don't normally say, well, I have, the problem is that I have one, disc that's too small and my spine's a little bit out of alignment and I got some degeneration and this is what she was telling me. And I'm like, okay, I see some of the findings maybe that you've come across, but what's wrong with you? Like what? And she continued. She was like, well,
the parrot
you see, like, it's like the bones weren't exactly aligned. And I was like, no, I think you're misunderstanding me.
Yeah.
What is causing you pain or discomfort on a daily basis? And actually I'm speeding this up. It took several rounds of this questioning before I actually had to lay it out so simply. And it wasn't because she wasn't super bright. It was because she's trying to tell me what she knew to be her problem. And I'm saying, no, don't tell me what everybody's told you is your problem. Tell me what you feel. She's like, oh, okay. Yeah, no, I'm stiff in the mornings and my back kind of hurts sometimes. And also the front of my hips also hurt. I go, thank you. That is what I was trying to get to.
Right.
Okay. Yeah. And that's the basis of that encounter, and then we go into, okay, let's just start from, I understand what you told me. I'll take that into consideration. Let's also look at maybe why those issues can be there.
Right. Yeah. I mean, when patients come in, after a while, you start to recognize that they have in their head a story that they think they have to tell you. I mean, I think when she was telling you, she wasn't like, I'm here to try to stand in the way of you treating me properly. She was like, I think this is the information you want to know, because there was another doctor perhaps who told her this is the important information. And so like immediately as a doctor, you need to know that you're giving people information, white coat syndrome or not, where they're going to carry with them. This patient carried that information over to Bobby, and she also carried it with her in between, by the way. So she's over here thinking her back has bones that and the space between them isn't kind of enough, and they're not quite in a line. And that's what she thinks is wrong with her back. But really, and this is some question, kind of a series of questions that I asked, like, what was it? Why is it that you came in now? Did you hurt yourself yesterday and you can't get out of it? Do you have a volleyball tournament this weekend? What is it that made you come in now? And I get the same response. I'm thinking of a patient. He was like, yeah, my x-rays were they kind of showed how my hips, like one was kind of longer than the other. And I was like, okay, but why did you come in now? Or what is it you have coming up that you need to be ready for? Like, what is the change? There's something, I think that there's something the patients can't change. They don't know what that change is, but they know that somehow you hold the secret to that. You know what I mean? And she thought she needed to change how her bones are aligned. It's hard to fix that, because then do you take an x-ray and go back? Like, that's what I think I mean by fixing fake problems, right? How did you address it? Yeah.
Well, they're not fake inherently, the idea that you can have degeneration or disc space issues, right? Mm-hmm. They're fake in the sense that just as the patient is telling a story to themselves or in their own mind, the clinician, the chiro, the PT, the medical doctor is also telling a story in their own mind. And that can sometimes be the most detrimental story, to be honest. I mean, sometimes we tell a story that now lives on in this person's mind, and the whoever was telling the story, whatever professional was telling the story, but maybe thought it was benign to mention something like, oh, you have this degeneration in your spine and you're only 25, it's not good. And that story now lives on in that mind that you just left behind. And you could care less if they come back in or go somewhere else when they live on to keep telling themselves a story. And that's something that I don't ever want to participate in personally, unless it's really important that they do have some worry. If they do have cauda equina syndrome, you probably want to make it important to them to know, hey, this is serious. And I'll tell my patients sometimes, this is an injury you need to respect, trust me. Right. And they can see that my demeanor turns and it makes a difference. And they pick up on that. But normally, and there's different ways to go about doing it. And too, I could say, well, research shows that there's no correlation between degeneration and pain. Like, well, that's kind of dismissing them. What you could say is, hey, do you have grandparents? Yes.
Yeah.
Well, do they always have low back pain? No, actually. Like, I can't remember my grandma in pain. Mm-hmm. They have pure degeneration of their spine, I promise you.
Yeah.
So you can find other ways, and you don't have to talk like that. You could even be more subtle about it. You can tell a story where they can pick up on, you could tell a better story where they go, yeah, that makes a ton of sense. My grandma, of course she has degeneration. She doesn't have any pain. Instead of saying, no, listen, I'm the doctor. The research shows there's no correlation between disc degeneration and pain and future outcomes of performance. Like, well, that's great that we know that, but it doesn't matter to them. So the story we tell is super important, no matter how how benevolent we're trying to be with the patient.
For sure. No, I think that the story idea, like I think there's one other distinction I want to make between the story. So like that the person has back pain. Their pain is real. However, they're trying to connect the reality of their pain with discs out of alignment or bones out of alignment, right? And in their head, they can't go, I wake up every day, I must sleep wrong because my bones are out of alignment. really all I hear is I wake up, I have back pain. And
Mm,
they've added this, I've got this alignment thing, I've got these discs doing this thing. They've added a little extra meaning. True or not, you can verify these things in some form or fashion to the patient. But then they make their whole pain every time they feel that back pain. It's now the disc is out. The disc is out.
mm,
The disc is out, or whatever. The nerve is pinching. The nerve is pinching. Right.
mhm.
Every time, and they start to miss what's really happening. Oh, I was sitting for an hour and a half. And so I think a lot of times I've heard you kind of dig a little bit deeper, I think, with patients and get to their Simon Sinek, get to their why a little bit more so, right? Get to what is happening in your life that you took the time out of your day to come into my office. People
Mm.
don't, as much as I think people like me, they don't want to be there. People got stuff to do. You know what I mean? So if there's something that has interrupted their life to some level to get them to come into your office, you deserve to take a second and see how serious it is. Treat it seriously. Treat them, clarify. What do you mean by this? What do you mean by that? Can we really get down to like how I can make your life better? Because they don't really care if their bones are in alignment until you tell them, right?
Yeah, and I mean, even if that stuff was accurate and research wasn't pointing to the opposite, actually, let's
Right.
just say it does point to that. Degeneration
Sure.
does cause pain. I'm still not so sure that's a great thing to tell them,
Right.
because we know so much of this is, biopsychosocial. There's so many other aspects to,
Hmm.
you know, y- to dealing with your pain. Sometimes when I tell, like, every clinician that's listening to this knows those medial shoulder blade knot pains that come on all the time, right? Definitely CrossFitters, gymnasts, throwers,
Hmm.
regular people as well, but everybody knows those pains, right?
Sure.
They can be extremely painful. I mean, I've had people come in who can't breathe deeply, they can't turn their
Hmm.
head, it's so bad. I just when I tell them, like, listen, this hurts, the worst case scenario is it hurts a lot. This is completely safe. If you had a game tomorrow, I could
Yeah.
say you're fine to play. It
Right.
just might suck. And you can, like, see it in their face that they calm down, because they
Hmm.
understand, like, nothing is gonna bad is gonna happen to me. It's just pain. And now all of a sudden the interpretation of that pain changes.
Right.
I remember somebody saying, if we didn't know that weightlifting was good for us, we would think we're dying. When
That's it. Yeah.
you're doing like
Good
drop
point.
sets to failure, like that pain, if you took away the entire perception
Yeah.
that this is a good thing,
Yeah.
you would think like you have to get to the emergency room now, like something severely wrong you are dying,
Right.
right? So it's
Yeah.
a matter of perception. And so when I take that little shift in their mind, they become optimistic now, and they're going to be a lot easier person to work with, to be honest.
100%. That's interesting you said that about perception. I think that's the perfect way to say that. I think a lot of people don't know that their problem is that they do not have the freedom of perception. When one thing happens, it immediately leads to this thing. And they see something very similar and it immediately leads to that thing. Like the pain story I think the Butler uses is the guy that was like walking through a field and one day and got bit by a snake, almost died, bit his leg. It was a whole thing. He's got a big scar, it wore away the skin. Anyways, a whole ordeal. 3 years later, he's walking through the same field and walks by, and a little stick just kind of scratches his thigh. He freaks out. He starts grabbing his leg and rolling around because he thinks that's it. And he looks down, it's just a little stick cut and he's fine, everything. But like, things that fire together wire together, you know what I mean? And so they've got this pain and it is wired to some sort of thought. Sometimes that thought is BS, sometimes that thought is perfect, but you need to know that there's a difference between like what is happening in reality and like the meaning they've attached to it. And I think kind of clearing away some of the clouds, that vague part of the meaning, real or not, is kind of your goal to help the patient. Like, you're supposed to give them some clarity and they're supposed to be able to trust you. And once you kind of clarify things for them in that sense, distinguishing their symptoms from what they think about their symptoms, two totally different things, I feel like then we connect, and it
Yeah.
brought it back.
Yeah. And sticking with this, I didn't know the
Yeah.
story from Butler of
Okay.
the snake thing,
Mm-hmm.
but sticking with that analogy, I would say you as the clinician
Yeah.
has the chance to to create a story for the patient in front of you.
Yep.
One of the stick is a snake, and
Mm-hmm.
one is the opposite.
Mm-hmm.
Like I don't know how it pops up on some of my social medias, but I have this guy who is like a snake, like a biologist that works with snakes, and I always
Okay.
see him on my social media. But anyway, he's constantly getting bitten by like these particular pythons and Burmese pythons.
Yeah.
He doesn't care at all. Like he's just so used to getting bit, and he goes,
Right.
"Well, it does suck if you get bit on the face. I really try to avoid that one." But he's like, "Don't worry, it's fine. They're
Yeah.
not venomous." And so if you can imagine if me and you were bit by a particular like a 20-foot python, you're gonna, and I don't even have a problem with snakes. I grew up in Arizona. I like snakes. But if I got bit by a python, I am not gonna be mentally
I'll lose it. Oh, I'll lose
balanced.
100%.
Right. And this guy casually gets bit and then just keeps working with the snake to like take the eggs and put them back in the cage. And it's just part of the job.
Yeah.
That could be the story that you leave with your patient.
Mm.
If you say, that's where you educate them and say, yeah, you do have this meniscus issue, but you can die with that meniscus issue. You just have to have enough function in there so you don't keep ripping it, or, you're not have this torque that's going through your knee every time you go for a jog. We just got to address that. And that little tear is completely normal. I mean, hip labral tears, slap tears in the shoulder, these things are so common. It's crazy. We just need enough function that they don't hurt you every day. And now they're walking in that field the next time and they feel maybe even they get bit again, just like the first time they get bit and they go, I know how this goes.
Right.
It's going to suck. I'm going to have a scar. I got to get to the emergency room, but I'm going to get through it. And they're versus the one who grabs their leg and falls down in agony and didn't even check if it was an actual snake bite.
Yeah.
That's the person who says, this is my disc. I can't do anything. This is my alignment issue. I got to get to my chiropractor or my PT.
Right.
So you are part of telling that story. You're not all of it. The patient can tell themselves amazing stories, and it's not always your fault.
True. No, I think you're right. You would think as like humans, we would learn to deal with chaos, that like chaos was the norm. I don't know what year you're listening to this podcast in, future people, but this is 2020 and stuff is going on. Like there's just chaos and over from all sorts of angles, from nature, from earth, from our neighbors, but there is some kind of acceptance of that chaos, and just like it's nuts. And you know what? I woke up the next day, like sometimes I think about this, the New York taxi cab driver story. I think Butler kind of I've heard him use this one as well, where in New York back in the day, there were taxis, not just Ubers. And these taxis were crazy. They were everywhere. Traffic in New York City. Very often these taxis would like bump into each other. No big deal. They would park, they would skid, they would drive off. These yellow taxis are all like scraped up, right? Not a big deal. Sometimes the tourist is like in the car, something that happens and they freak out. The taxi cab driver just moves on. Versus like the mom here in San Antonio, Texas at the local grocery store pulls out and, barely nicks somebody else, loses it, right? But that's the same sort of thing. Like, what have you kind of normalized? I'm not telling you to tell your patients to normalize absolute chaos, but like if you get bumped, let's just know that it's a bump and your whole transmission hasn't failed. You know what I mean? How can you get that message to them easily, smoothly, so that they understand that and that they can kind of work with you and you can buff some of these things out and you can build some strength on top of your taxi, right? I think you want to buy time to kind of protect them in the long game.
Yeah, that's all right. I mean, I do think there's still yellow taxis in New York because they outlawed Uber. Isn't that right?
No, there still is. They outlawed Uber?
I don't think Uber's legal in New York. And if it is, it's only recently.
Oh, okay.
Well, because it would put all those taxi guys out of business.
That's true.
But
this is still 2020. No, this is 2016. Then we can make the yellow taxi thing work. No, so you're okay. So let's wrap this up. when you have patients, try to realize there are symptoms and there are things they think about them, right? Whether it's from them, whether it's from Google, from Instagram, from idiots like us telling people what their problem is, and there's what's actually going on, and try to distinguish the kind of haze around the actual thing that is going to help that person. And if you can connect with that and you have the skills to connect with that, I think that's a successful day in my book, right?
Yeah. And just a little bit on the clinical side would
Yeah.
be a takeaway. We've always been proponents of expanding your toolbox. And if your toolbox only has one instrument in it, a hammer, everybody uses a hammer, a tiger saw. If you only have a tiger saw in your
Yeah,
toolbox, it's a
sure.
big toolbox, then everything you see is something that needs to be cut. So in other words, if you're a manual therapy person, you will tell your own story that every person that comes in your office has a myofascial issue. If you're a trainer, everybody that you see has a strength issue.
Mm.
If you're a chiropractor, everybody you see has a joint issue, maybe specifically a spinal joint issue. You see
Mm.
what I mean?
Mm-hmm.
It and in reality, you could be accidentally or purposefully correct, or you could be accidentally or just ignorantly completely wrong, that it has nothing to do with the tissue in this instant. It was only a joint issue,
Mm.
or it has nothing to do with the joint. But if all you had was the tiger saw, it doesn't matter. That's your tool. And unless you're somebody who's really good at referring out when it doesn't fit your macros, right? Then you are going to be telling a story that is going to be a bit of a leap, a bit of a false story to try to fit your personal toolbox, right? So you either have two options, like ethical options in my mind, which is to expand your toolbox or be somebody that's really good at getting people to the right place.
Mm.
And in my experience, clinicians, and even in my own, we all want to help everybody and think we can help everyone. So I'm guilty of this as well. I don't see people refer out very often,
Mm.
almost never. Okay. So not intentionally, people will just leave of their own accord usually. So maybe, my challenge to the clinician would be maybe question yourself and your own stories that you tell, and see if you're not building a story around your tool every single day. And if you think maybe you are, well, partially that's not your fault. You're doing the best you can, but
Mm.
maybe you need to find some more tools.
I fully agree. And I have such a good counterpoint right now that's going to make you look really dumb. And I don't want to say it. It doesn't make you dumb. It's just a little bit different. Okay. So we were going to end, but screw it. I'm thinking about it now. I love arguing with Bobby. I don't disagree with the toolbox thing, right? I totally agree with everything you said. There is one problem I have with even the toolbox hammer metaphor. And I think about it in this way. Imagine that you're a chef in a restaurant and a patient comes in to eat. Okay. Um, you go out there and you go, hey, welcome to the Anatomy of Therapy restaurant. What would you like today? And the patient goes, I'm really hungry, trying to lose weight, been working out, and I want a double quarter pounder with cheese. And I heard the double quarter pounders of cheese are really good. I heard fries, ketchup. I heard you make a secret sauce. My friend told me there was a secret sauce. I don't really understand it, but apparently it's amazing and I need it. Give that to me. I'll have one of those, please. And you as a good chef go, what do you mean you want double quarter pounder? What do you think that's going to do to help you lose weight? Well, my friend, and they'll go into this whole thing. But what you're doing is you're collecting information on this person. You know what I mean? You're like, what did you eat earlier today? What are your other favorite restaurants, maybe? Right? What kind of a workout are you doing? Have you ever had a double cheese? Have you eaten from here? Have you tried this? Right? And what happens is you are gathering data on this person, right? And I think this is what a good doctor does. I think about this it's a Steve Jobs quote. Jobs quotes? Steve Jobs quote. He says he was asked how much research Apple puts into its products, and he goes, "Oh, none. We don't find out what people want and give it to them. We tell them what we want. We tell them what they want. No, we tell them what we want," is what he said. And I thought he misspoke. And he's like, "We tell them what we want." You know what I mean? This is Steve Jobs confidence, right? So what happens in the doctor, my backstepping with that is that you're not necessarily doing research. You're asking questions. You are doing summary. You have to make some connection there. But at some point you go, okay, I've got enough information, ma'am. I know you want a double cheeseburger, quarter pounder with cheese, but I'm gonna go into the kitchen. I'm gonna whip up prime rib. I do this little sauce. It's delicious. I've got some carrots glazed on the side and a glass of water, I think. And anyways, you bring that out to them because that is what they need. Do you know what I mean? And the more clearly you can kind of enumerate that, like you're like, look, I know what you want. I know you think you know what you want. And you can kind of deliver them a prime rib. And then you step back and they go, yeah, that was it. I'm happy with this prime rib and I'm going to kill my marathon tomorrow. But the only difference is the perspective of chef onto the restaurateur or whatever, right? The client, the patient.
I think you thought that was a counterpoint. That is not a counterpoint at all, because I completely appreciate that chef clinician.
Sure.
That chef clinician is loaded with more than one tool. You just listed like 5 different tools he has. He can make other things. He can make different items on the menu. He knows how to communicate with the patient. He knows how to question and get to deeper reasons. All those are tools. Communication is one of them. So you just listed a bunch of tools. I'm saying if you have one tool and you build a story around that one tool, and then you tell the patient their story is this problem because of the story you have in your mind, which is only one way. That chef didn't do that. He didn't have a story. He had a goal. He had a thought process. He had a communication with the patient, the customer. I like that. I like that chef. I would go see that chef.
Yeah.
It was a great point. I guess we don't.
No, I guess we don't disagree. I want to find a way to disagree with you now, just because that's what I wanted to do, and I feel ashamed that I didn't disagree with you. I was just trying to build a better story around your story.
Maybe it's
see
more
what I'm doing here. Are you keeping up?
Maybe it's more the idea that if he says, "Hey, you know what? The double quarter pounder is not really healthy. You told me your goal is this.
Right.
I have some lean elk in the back. How about that?" And they go, "Listen, chef, I'm the customer.
Yeah.
Today I told you that's my goal, but I don't give a shit. Right now, what I want is a double quarter pounder." Then you go, "Okay, I'll make you a double quarter pounder." Maybe that's what you mean, because in that case, somebody says, you try to tell them, "Well, you know, this is really what you need. You really need some hip internal rotation. Your spine doesn't segment. You're very unhealthy. Listen, can you crack my back or not?" In that case, maybe that's more of your point. In that sense, it's like, what is right or wrong if that's what the patient wants? And if it's not unethical to give them what they want, maybe you don't have to, you know what I mean? Like sometimes people find you based on your tool that you do have. And even though if it doesn't match up, that's why they're there. So give them the tool that they came to, you know.
Fair. Yeah. I think if you're a good enough doctor, you should be able to understand why they want a Big Mac or whatever, and find the gaps in it. If you're listening, that was one of the things too we didn't really pick up on. I think you were listening to your patient better than most doctors listen to their patients, because they go, "Your spine's out of alignment, cool, lay down, gotcha," and they don't go any further. This chef listens to them just a little bit more to understand that, the double quarter pounder of cheese is what they think they want, but the reasons for wanting it don't align with their end goal to run the marathon the next day or whatever. We're on the same page.
And
I love that's why I have a podcast. I hate it. I don't want to be on the same page with you.
If you're a new
voting for, I'm just kidding.
Walter Reed Medical Center. If you're a new doc, if you're a new doctor, you don't have a big toolbox yet. That's fine. I'm not judging you. All we want you to do is maybe ask the question, like maybe interrupt the thought process. "Oh, Okay, you have disc degeneration. Lay down. Let me do my thing. No, just ask the question. No, well, hold on. Like, but what's wrong with you? What hurts? What do you feel? What's your problem? What are you not able to do because you have this pain?
Right.
And maybe you don't have the tools to fix it, but just by asking those questions is the only way you're ever going to find tools to ever answer these questions. If you don't ask the questions, well, then your operating system is just to use your tool as you know how to do it, and that's it. You're just
Yeah.
cutting everything with a tiger saw all the time.
Let's get a tiger saw to sponsor the podcast, I think.
Yeah, let's get it.
What are you stopped by? What changed? What do you need to be able to do? Like, these are questions you have to ask your patients. If you can get it back to their life, back to things they care about. You know what I mean? That's a good doctor. That's a doctor that's connecting with his patients beyond their anatomy. Let's stop. I gotta go watch football, dude.
Let's argue next time. We'll find something
Your
more
shirt's
contentious.
dumb. I don't know. All right, man. Thank y'all for listening. Tell a friend, give us a 5-star rating, and all the stuff and the things. Smash that like button. Later.
See you guys.